email. But as we get started in this next session, which is Cultivating Competence in Crisis Situations, this is our suicide prevention session. I want to introduce our presenter, Jan Thornton. Jan is a clinical associate professor of social work and the director of student counseling at Utah State University Eastern, which is a satellite campus of USU. She spent her early career working with youth in both juvenile justice services and the Division of Child and Family Services, before ultimately coming to USU Eastern, where she has fulfilled numerous roles in student services before transitioning to faculty in the social work department. So we thank her for providing this training for us, and Jan, the time is now yours.
Thank you, Teresa. I tried really hard to get her to just introduce me as this is Jan, but she's much more professional than I am. I also just have to say before I start, I realize that I am the last thing standing between everybody and their weekend, which is not the place that you want to be as a presenter on a Friday night. So hopefully this information will be valuable for you all. I was actually scheduled to give this presentation last year at our conference, and I had to back out due to some medical reasons. And one of my colleagues graciously stepped in and gave the presentation for me. And I was then asked to come this year and try to give the presentation I was unable to give last year. So I have a little bit of a disclaimer in that if you attended last year and listened to Jocelyn give the presentation, there will be some overlap in the information. And I've tried to update it and add some new things, but at the same time, I think I just wanted the opportunity to tell my story and tell my material. So I also just want you all to know that this really is based on my experience in the field, some of the training that I've been to, information that I've come across in the years that I've been working in the field, and probably some biases that I hold based on those experiences. And so I'm not a suicidologist, but hopefully I still have something to offer to all of you. So I will also just say that I probably have more information than what I can conceivably get to in 50 minutes, but I will do my best. And I have a lot of resources that I've listed out for people and a lot of resources that are in the chat from Teresa. So hopefully you will look into those if you are interested. And I think it's important for us to really just think about how, one, this is such a sensitive topic, but two, it really is something that requires really careful consideration and really skillful communication when we're working with our clients in the therapeutic setting. And we play such a crucial role in assessing and addressing those risks for our clients. And I think asking the right questions, even when those are difficult questions, is essential for evaluating risk. And we'll talk about some of that as we go through this today. So I have 3 objectives, and I'm not going to go through them all right now, but they're listed out as we go throughout the presentation. So I hope I can clearly show how I'm intending to cover those. And to start off, I feel like it's important to tell you all that my views are always evolving as I read and I dig into the research and I think about the people who I've worked with. And I have a few biases that I'm bringing to the table today. And one bias is I really believe that the best intervention that we can do is good prevention. And more than anything, I hope people hear that. And I've come to this opinion in a number of ways, but I'm going to just try to hit on a couple of really quick things. You know, one, I first really started to question how we assess and treat suicide when I attended a training in about 2009. Jack Clott was the presenter, and it was the first time I was introduced to the concept of the psychological autopsy and how that could inform us in the work that we're doing with individuals. And he talked about 6-week and 6-day warning signs and a number of things that came from these psychological autopsies, and then talked about how he felt like we weren't making a dent in the numbers because of who we were focused on. And he specifically identified who he called suicide ideators and suicide attempters or completers. And he essentially made the claim that we weren't making a dent because we focused so much on ideators, and that stuck with me throughout the years. Then kind of moving forward, I came across a book that much of the presentation today is going to be based off of, and the infographic that is in the chat. And that is Stacy Friedenthal's work. And I felt like it at least gave me really actionable steps of what to do beyond my own training and experience. So if you've read her work, today might just be a little bit of a reminder with some of my little anecdotes filled in. If you haven't, I highly recommend it. I'll probably recommend it 16 times while we talk today. And then I was in another training with Janina Fisher, and she suggested that when working with suicidal clients, she suggested asking, when you think about acting on your suicide plan, do you feel more or less anxiety? And again, it was sort of this moment in time where I thought, oh my goodness, that is such a great question. And so I incorporate that now as I work with individuals in treatment. And then finally, I recently read a book called Rethinking Suicide. And once again, I started to question everything that I thought that I knew. And I don't want to get into too much detail with this because I feel like I'm still trying to sort of formulate my opinion. But there are some really great critical thinking questions that he asked in the beginning of his book. And even as I go through and I talk about all of these ways to assess and intervene, I hope you keep these questions in the back of your mind as I will be doing today. So how do we know that asking someone if they're thinking about suicide will save their life? And how do we know that all suicides are preventable? How do we know what constitutes a suicide warning sign and what does not constitute a warning sign? How do we know that suicide is caused by mental illness? And I've actually put a meta-analysis in the handouts that I would encourage you all to read that really digs into that question. How do we know that mental health treatment will prevent suicide? And if we're so certain about what causes suicide and what needs to be done to prevent it, why are we so bad at it? And I think back to some of what happened kind of in that morning conversation about bad therapy and what Mike shared. So, and then of course, what if we're wrong? And the reality is that we don't know why some people die by suicide and why others do not. We know some things. I don't want to say we don't know anything. And we don't necessarily know why suicidal behaviors occur when they do, like why on this day instead of this day, why, like Saturday evening instead of Saturday morning or Friday afternoon. And at some level, I think there are some strategies and solutions that work better than others, but I don't know that we have a single perfect solution or combination of solutions that we would call correct. So I'm giving you what I know based on what I've dug into, and hopefully it will be valuable for all of you. So I really, when I teach in my courses, especially my practice courses, I always talk about this quote. We treat people, not behaviors, not problems, not symptoms, not diagnoses, not addiction, not statistics, not anything. It is people. And I think we have to remember that as we go through everything that we're talking about today. It's about the people that we're working with. And I want to talk about a few little things that have happened to me throughout my career that have shaped me. And this picture on the slide of this individual is not somebody who died by suicide. However, this is my very dear friend. And I got a phone call in the summer of 2007. And He said, I just came home and my partner was dead. He had taken all of the pills in the house, and I don't know what to do. And I jumped on a flight and I flew out to Georgia, where he was living at the time. And I spent the next week with him as he went through setting up the funeral and doing everything that entailed. But what stood out to me more than anything, and I think it's important to know, I hadn't had much experience with crisis and suicide at the time, but I remember sitting there next to him while he was sleeping, and I watched him sound asleep, crying in his sleep. And that left a real significant mark on me about the pain that was left behind. Then, as I'm kind of moving forward in my career, I often tell the story of my first crisis on campus. And I received a message late on a Sunday night that said, Jan, my knives are talking to me. And at the time, I lived 30 miles away from campus. I was expected to respond in crisis under that administration. And I had the most frantic 30-minute drive of my life to get here. And when I walked in the room, this individual did not have like steak knives. They had swords, and there were about 7 of them in the room. And that experience started to shape who I was and how I responded in crisis. Then moving forward, I was sitting in my office one day with a young lady. And as we were sitting there, she started to tell me about how suicidal she was feeling and how she just didn't think she could go forward. And as we were talking, we made the decision that we were going to call her support system and try to get them to come and pick her up so that we could get her to the hospital. And as I was talking with her mother on the phone, her mother said, "Where's her gun?" And I looked up from the phone and I said, "Where's your gun?" And she reached over in the purse that was sitting right next to her and picked up her gun and handed it to me. And that shaped me because I didn't think to ask about the gun until her mother was on the phone and was suggesting that I should be asking. And I remember that now. I don't forget to ask that question anymore. And then finally, if I believe for many of us, if you're in the field long enough, you will eventually have the experience of having a client die by suicide. And that experience happened to me just about 6 years ago. And that's the airplane in the corner, is that representation. And so all of these experiences have shaped how I respond in crisis and what I do. And we all have these experiences. We all have these moments in time that push us to do things a certain way. With my friend, I never wanted somebody to experience the pain of losing somebody like that again. I never wanted to hear about somebody crying in their sleep again. And I responded in a really passionate way to crisis because of that experience. So I have a little poll. Hopefully it works, everybody, but I want to just talk a little bit about what are our own attitudes toward crisis? What do we bring to the table? And I think you can either go to the website or scan the QR code to be able to take this little survey. It's about 8 to 10 questions. I'll give everybody a second to get logged in. Looks like people are about halfway done.
Do we need to register?
I hope not.
No, you should be able to just skip it.
Yeah, I think you can just skip. I think I'm going to go ahead and just start talking about some of what I'm seeing on the results, which I'm very encouraged at some of the numbers. So I feel confident in my understanding of what constitutes a crisis situation. And about 90% or 85% are agree or strongly agree. Very few on the lower end. I believe that every crisis, regardless of its nature, requires immediate professional intervention. And it's pretty much all over the map on this one. The only one that's low is strongly disagree, and then it's pretty equal across the rest of the answers. I believe that suicide is a choice, not a consequence of a crisis or a mental illness. Mostly disagree or neutral. A couple of agree or strongly agree. I find it difficult to empathize with individuals who have suicidal thoughts. Strongly disagree, a couple on the agree or strongly agree. And I think this is important to know before you start working in crisis situations, because it often requires a lot of empathy to sit in the room with somebody in the midst of their pain. I feel that individuals experiencing psychosis are beyond help. Mostly at disagree or strongly disagree on that. I'm comfortable dealing with a person in a crisis situation. Hooray, I have about 2/3 say agree or strongly disagree. I have adequate training to manage someone experiencing suicidal ideation. Mostly agree or strongly agree. I believe that my own emotions and reactions have sometimes hindered my ability to help effectively in a crisis. Mostly on the agree or strongly agree, with some on the disagree. I'm aware of how my cultural background influences my approach to crisis. And again, mostly agree. And then finally, I've been affected by a crisis situation in a way that changed my approach to work, which, as you all heard, I definitely have. So, and it's by far the majority say yes. So that tells me that a lot of people have some level of personal experience here. And I think it's so important that before we walk into crisis, we really know ourselves, and we really know, like, do we view suicide as selfish? Do we view it as a sin? Are there circumstances where people might consider it for themselves, or is it incomprehensible that they would consider that? So do you know that about yourself? And take stock of your experiences and your lack thereof. My first crisis situation was the young man who sent that message who said, "My knives are talking to me." And I had left working at DCFS, where I primarily worked with 5 and under. So I was panicked that day, and grateful at some level for my prior training in juvenile justice that allowed me to, the poll failed. I'm so sorry, everybody. But it allowed me to at least have some level of comfort in intense emotional situations. But I panicked the entire drive, and then I got there and went, okay, I got this. I can handle it when I finally arrived. But I think it's so important to be aware of the negative feelings we might have toward people, sometimes from our own past, sometimes from other people maybe in our lives. And sometimes I think we have negative feelings because I think we at times as clinicians get upset when people are not improving. And it affects who we see as who we are as clinicians. And so sometimes I think we blame our clients for not getting better. Or maybe we just resent them because they have some level of power over us, right? And so maybe we feel manipulated or blackmailed or coerced in some way when we're working with them. And I think we have to face our fears. Like, if we don't do that, I think we'll really struggle to intervene in these types of situations. So I've spent a lot of time and a lot of investment in trying to learn more and face those things that were so scary for me in the beginning. So ironically, I I'm famous, if anybody has ever had me in a class, I'm famous for adding things like 4 minutes before a presentation starts. And this was probably 12:30 today. But I really liked this slide from a clinician by the name of Justin Baker. And he basically said, we spend a lot of time in the suicide world talking about the why. And very rarely do we talk about the how. But it might be really important to consider this how as we go in and as we work with people. And just as an example, he talked about a car accident and how if we only focus on the why, we're just going to be focusing on the driver and what the driver did. But maybe the conditions were really icy. Maybe there wasn't a guardrail where there should be. Maybe there were other factors that were going on that were really more about the environment and the how that could have made a difference in that case. Maybe it was the driver, but maybe it was the conditions around them. And so, I think it's worth considering that sometimes we can engineer the environment in a way for some level of suicide prevention. And specifically, I'm thinking restricting access to lethal means. So even though we're going to talk about assessment, I don't want people to forget that. I think it needs to be highlighted, shouted from the rooftops, and repeated multiple times. So in terms of conducting assessments, I just want to start here. And this is Stacy Friedenthal's book. There's a handout that I created with the tips that come from this book. And I just found this book to be so valuable in terms of figuring out, what I was asking, why I was asking it, and sometimes even how to ask it. So I call it kind of the MBB of books for this work. And much of the presentation is based off of her book. But number one, we have to directly ask people about suicidal thoughts. And I'm forever grateful for my time in JJS because I'm very comfortable asking, and I'm very comfortable just saying, are you feeling suicidal? Are you thinking of killing yourself? And I don't have to beat around the bush. I don't have to say, oh, do you feel like you might want to hurt yourself? And I would even caution all of you to get really good at being really direct. So the book is at the end of the slides too, just for the person in the chat. So I think back to Kevin Hines, who jumped off the Golden Gate Bridge and survived. And he said, nobody ever asked me if I was experiencing suicidal thoughts, so I didn't feel able to disclose them to anyone. And if we can't ask about it in therapy, I think that's problematic. Now, for some people, I think they feel more comfortable doing more of a hierarchical approach, but I like to just dive in for the question and just ask. And I also believe that just asking once might not be enough. We might have to ask 2 or 3 times until we feel very reassured that that information is true and correct. And there are a number of things that we can do to elicit sensitive information from people. And I am curious, maybe in the chat or if anybody wants to jump in here, but what are some of the skills that we learn for asking these hard questions? I'll give one. Oh, yeah. You are way ahead of me, Samuel. But yes. And I'm thinking things like, let's normalize it for people. So maybe we say many people with depression like yours feel so bad that they think of suicide. Have you had suicidal thoughts? Right? Let's just normalize it. Maybe the idea of kind of shame attenuation. So we blame their situation or their pain or whatever is going on, right? Like with all of the things that are happening in your life, do you think about killing yourself with all of that that's going on? Sometimes we have gentle assumptions, like how many times in your life have you attempted suicide, if at all? And one of my favorites is really the symptom amplification. So how many times a day do you think of suicide? 20, 30, 40, 50, right? And they might respond and say, no, not that much, like 5. And so it's a way of garnering that information from people. So, and a really accurate understanding of suicide risk starts with a thorough and detailed understanding of their suicidal thinking. So, and we have to, I think, remember not just to ask about the thoughts that they're having, but maybe the imagery that they're having. So, and then how do the images make you feel? Do they comfort you? Do they disturb you? Can you control them? Do you want to stop having them? Do they make you want to even more strongly want to kill yourself? Do they make you want to stay alive? When you think about suicide, what do you see? Have you rehearsed it in your imagination? And then, of course, all of the things that I think most of us have been taught as clinicians. So precipitants, reasons for wanting to die, frequency of thoughts or images, intensity, duration, method, means, preparation, planning, intent and timing, controllability, history of attempts, worst suicide ideation ever. I love what Mike put in the chat with the SLAP method. And it's helpful to ask about non-suicidal self-injury. And I found when I did my first training back with Jack Clott back in, a long time ago, I found the way that he framed it to be really useful for non-suicidal self-injury. And he talked about basically that there are 6 essential reasons why people might self-harm, and being certain that we know why they're doing it, and really that only one is a rehearsal for suicide. Oh, I feel like somebody just tried to talk. Oh, maybe not. So, and then also knowing what is not self-injury. So things like, generally speaking, tattoos and body piercing are not necessarily considered self-injury, right? So because they're performed in more of a social context. And we want to make sure that we're privileging warning signs over risk factors. So think about what would be warning signs as opposed to risk factors? Any guesses? So things like intensity of thoughts, talking or writing about it, making preparation. I saw that in the chat. Agitation, anxiety, anger, things, feeling trapped, sleep disturbances, withdrawing. Whereas risk factors are prior suicide attempts, psychiatric illness, prior hospitalization, things of that nature. So not that it's not important to know, but the warning signs are much more helpful. So, and then honestly, like the evidence is there that we have to assess for firearm ownership and access to that firearm. So we might be saying, how many firearms do you own? Do you have plans to get them? Do you have access, even if you don't own one? Is it there in the room with you, in your purse right now, as we're talking, right? As what happened to me. And then I think it's useful to say, have you been Googling this? Have you been on the internet? What are you looking up? What are you finding? And we cannot forget to probe for homicidal information. And, in my career, I have very unfortunately worked with more than one situation where there was a homicide or a homicide suicide together. So, we need to make sure that we're asking and all the same questions just in relation to somebody else are helpful to ask. And we want to be collaborating with other people. Are we getting the information from them that we need? Sorry, my slides don't want to move. We also want to look at reasons for living. And I think I posted or had Teresa post one in the chat. And, but so it's so important to also ask, why do you want to live? What are your reasons for staying alive? What used to be your reasons, maybe? What made it life worth living for you before things felt so bad? What would be your reason if you felt better? And we also want to look at protective factors, things like hopefulness and optimism, social supports. How are they at problem solving? What do their coping skills look like? How's their self-esteem, their sense of competence and effectiveness? Are there cultural sanctions against suicide or religious beliefs around suicide that could be protective factors? And, one really fascinating piece of information that I remember out of that very first training that I attended is they talked about there's one group where the suicide rates are incredibly low, one population. And I'm not sure if anybody, well, if you've been in my class before, you might know, but does anybody know what that group of individuals, who they are? I never would have guessed it if they hadn't told us in the training. But it is elderly African-American women, older African-American women. And they went in and they said, well, let's figure out why. Why are they the exception? What's going on here? And what they identified at the time, and it could have changed now, but they identified basically 4 factors. And they said, well, these women have this really strong sense of resiliency. And they have this idea of, well, if that doesn't work, that's okay because I have a plan B. And if plan B doesn't work, well, that's okay because I have a plan C. And they could go on C, D, E, F, G, H, I, J, whatever. They also had a very strong sense of hope. And for them, it was very faith-based. And there was this sense of radical acceptance of life. And so it was, sometimes really awful things happen to really good people for them. And then finally, a really strong sense of social cohesion. And so I always think about that as I work with people and think, are these things that are existing in this person's life? Are these things that I can foster in this person's life to maybe help be protective factors for them? And I think it's also helpful to know how people view suicide in terms of whether or not they view it as being acceptable within their culture. I think it's worth asking questions like, how religious of a person are you? How do your religious beliefs or community add to or take away from your stress? What does your religion say about suicide? And then I think just soliciting their own level of risk. What do they think? How likely is it that you're going to kill yourself if you leave this office today? What about in a couple of days? What about in a week? How safe do you think you are from acting on these thoughts? Today, tomorrow, maybe, in 3 weeks. So, and don't ever assume that you know why they want to live. And I have a story from a QPR training that I took that the trainer shared about a mom who, she was such an amazing mom. She had these, wonderful children, and the treatment professional came in and said, well, you don't want to kill yourself. You're such a good mom. Like, your kids could never be raised by somebody else. And her response to that was, you're right. And that's why I'm taking them with me when I go. So, don't assume that we know why. And another sort of side note is that that's somebody with no barriers, right? If it's somebody that says, this is the most important people in my life, I'm willing to take with me, that person has no barriers. And then I think, for the most part, people have a pretty good understanding of levels of risk, but really at the end of the day, though, when we go through all the questions that there are, and I couldn't hope to possibly go through all of them in the course of 50 minutes, but when we go through all of those questions, at the end of the day, it's us as the clinician who is the decision regarding the degree of risk for them. And in some respects, it can be a subjective one. And so for me, I think I want to have as much information as I can gather to make the best possible decision that I can make when I'm working with people. So In terms of our more low risk folks, we tend to see very vague, kind of overly general, fleeting suicidal thoughts or imagery, no real report to act on those thoughts, and no objective indicators of intent or plans. As we kind of move up the ladder, if you see more medium, those thoughts tend to be more enduring or specific, but don't really have strong subjective or objective indicators of intent. Typically, there are some warning signs, and their symptoms tend to be worsening. And they may have even thought of ways to die and even possess some intent to act. So, but that intent tends to be kind of fleeting and coexists with this stronger desire to live. So, and then finally, with our high risk people, these are individuals who have intense thoughts, they have a plan, they have a means, and they intend to attempt, but not necessarily, it doesn't necessarily have to be the near future, but they're pretty high risk still. Or someone who's recently attempted and wants to attempt again, but maybe they don't have the ability at the time. And if you have somebody who's having command hallucinations, then that increases risk, and protective factors might not reduce risk. And then finally, imminent risk, you really reasonably believe that they're going to attempt within the coming hours or days if they're not protected. And generally that's 48 to 72 hours. So a command hallucination, the question in the chat might be something like someone who has a voice that says, cut off your arm, and they try. So, and then it's really important to document very generously. So you don't want to simply say that this person denies suicidal intent. So go through your rationale, document how you came to that rationale. So that might be things like the presenting problems, the stressors, the recent stressors, mental status, their diagnosis, substance use, trauma, maybe some non-psychiatric medical problems. I had a dear friend who lost a father when he was diagnosed with cancer because he didn't want to be a burden to his family, and he didn't want to pass that cost along to them. And then also make sure that you're not just documenting intent, but also document contradictory evidence of their intent. So if there are reasons to believe that they won't follow through, make sure you're documenting that too. So finally, I have to talk a little faster. I'm running out of time. So I love this quote from James Densley. He is a researcher who studies mass violence, particularly things like school shootings. And he said this quote, "A person in crisis is like a balloon that's ready to pop, and we just need to let a little air out." And in some ways, I think that feels a little bit reassuring to all as professionals, like, okay, I can help let a little air out as I'm working with this person and take a little bit of pressure off. So it's really important for us to know when we should pursue hospitalization and when we shouldn't pursue hospitalization. So if they are high or imminent risk, and the goals really are kind of crisis stabilization, not treatment or recovery, right? It's just stabilization. And I think we have to always remember that involuntary hospitalization is not risk-free. So I think it's reassuring to all of us as clinicians because we know that they're safe, right? Like, oh, I saved their life. They're in the hospital. But I worked with someone who she had felt pretty bad, and crisis services were called in. And her statement was, if you put me in the hospital, I will lose my job. And I guarantee you, I won't just be thinking about suicide, I will kill myself. So there are risks both ways. And I think sometimes our own anxiety about their suicide is what leads us to sending them to the hospital. So keep that in mind as you're making those decisions. Now, would I want somebody to not hospitalize someone who is imminent danger? Absolutely not. I would want you to do what we need to do to save life. But just remember, sometimes there are consequences to that. And it's really important to know that there is little evidence that no suicide contracts work. Instead, there's evidence that they don't. So I don't recommend no suicide contracts. What I recommend instead is a really thorough good safety plan with your clients that you develop with them collaboratively. And it honestly, in many ways, might be the most important thing that you do with them early on in the treatment. So and there's a number of great tools. I've put a couple on here for uh, tools to help you develop those contracts, but but asking those questions, like the next time you have suicidal thoughts, what will you do? What can you do to take care of yourself? Where can you go? I learned from a hospital worker one time to use, they called it the rule of fives. And they basically said, I just take both hands and I say, let's develop your safety plan based on both of your hands. And on one hand, what we're going to do is we're going to have 5 things that you can do for a minimum of 5 minutes to see if those thoughts will start to diminish as you go through that plan. So, I mean, it might be standing on your back porch blowing bubbles. Like, we don't care as long as it's something you can engage in for 5 minutes. So on one, it might be, well, I can go for a walk. And then it might be, well, I really like to listen to music. And the only cautionary thing I will say to you all, if you do use this, is if you have somebody who their plan is, I'm going to get in the bathtub and I'm going to slit my wrists. And then they say that the behavior they want to engage in for their safety plan is to go get in the bathtub, I would probably challenge it a little bit. And I would say, I don't know. I feel like that's kind of a seemingly unimportant decision that's going to put you in a really high risk situation. So what else could we do? So we do that. And then on the other hand, we come up with 3 people that they can call. So it might be mom, sister, brother, friend, partner, whoever. And then on the 4th finger, is I hijack the last 2 and I say, for this second to the last thing, I want you to think about if you're using all of the coping tools that you've learned in therapy. Are you taking your medicine? Are you taking it at the same time every day? Are you engaging in all of those things that we've been practicing in our treatment together? And then finally, the very last one is to call either 988 or whatever crisis protocol you have set up with that particular client. And then I write it all down for them so that they can take it with them when they go. But we memorize it with their hand because every single attempt that somebody makes at some point uses their hands. So, you know, if they're grabbing that gun, they're grabbing it with their hand. If they're getting that rope, they're grabbing it with their hands. If they're grabbing that razor, they're getting their hands. And so I want their hands to serve as a reminder, I have a plan, I have something that I can do. So that's not the only way to do it. In some ways, that's a little bit more informal than some of the other plans that you'll see, but I found that to be really useful in working with clients. Trying to get through here on the last couple of things. And so oftentimes if we can reduce the level of suffering, they will choose to live. And so, and then I think it's helpful to invite them to express their pain. How bad are you hurting? How would you describe your pain? What hurts the most? Where does it hurt? And how can I help you? I think we want to target that social isolation. So getting that sense of belongingness. And I think about things like cognitive behavioral therapy, right? Maybe their sense that nobody cares. You know, that might be something we can challenge that thinking. You know, where are their thoughts accurate and engage them in that problem solving. Reducing that sense of burdensomeness, sorry, that was a tongue twister. And really non-judgmentally and compassionately look at their beliefs about what they contribute to other people's lives. And at the end of the day, like we should assume nothing about that person that's in front of us. And we want to tap into that ambivalence, because most people, in my experience, it's not that they want to die, it's that they want the pain to go away. So tap into that as you work with them and start looking for exceptions. Frame it as their attempt at solving what's happening, right? And then help them work on other solutions. Give them options. We can teach them the problem-solving method that we all learn in our education. You might incorporate a hope kit with things like pictures and writings and souvenirs and things that have kept them alive so far, but things that would serve as symbols for them of hope. And highlight their strengths with all those amazing solution-focused skills that we have. And then, you know, there are a couple of treatments, and I might just kind of skip what's on the slide and let you look at this just so I can talk about these two things. But there really are two treatments that have been found effective in replicated studies. Those are dialectical behavioral therapy and cognitive behavioral therapy for suicidal people. And not that there aren't others that are in progress, but these are the ones that have been replicated. And so I would encourage you, if you really are hoping to have the skills to intervene effectively, I think those are two therapies that are worth getting additional training in. And then I want to just mention one thing off of this slide. I have found it to be extremely useful to do a psychiatric advance directive for people when they're feeling better. Not in the crisis, but when we move through the crisis and before there's another crisis, sitting down with them and saying, what is it that you want to happen should you ever feel this bad again? Who do you want to be involved? What hospital are you willing to go to? Who do you not want to be involved? Because when they're in that crisis, they might not want any of those things, but we want them to define that up front. There should be, it's the Wellness Recovery Action Plan in the handouts that essentially is like a psychiatric advance directive for you all. And finally, I just want to give people an opportunity to ask some questions. And sorry, I know that was fast, but we have 2 minutes left on a Friday night. There's a lot going on in the chat. I've tried to catch what I could. Oh, the last finger for Mike, that was calling like a suicide crisis line or whatever kind of final step you have, if that's your agency or whatever that might be.
Can I ask a question? Like this?
Oh, I think somebody's trying to ask, but it cut off.
Can you hear me?
It's really difficult to hear you, Jessica.
Okay.
Yeah, if you could put it in the chat. And other folks, if you have questions for the chat, feel free to put them there.
And actually, while we're doing that, I'm going to throw my slideshow back up with the resources. This is a lot bigger than it used to be. I keep reading because it's something I feel really passionate about. And still, even with 20 years of experience, I still feel like I don't know enough. My chat disappeared. Hold on. All right. Well, I just want to tell everybody, thank you so much for your attention, your comments. I wish that we had 5 hours together. There's so much more, but hopefully the resources that I shared with you all will be useful. And I really do recommend Stacy's book, and then the infographic that was in the chat that has the tips all come directly from her book. So.
Yeah, and it looks like we do have a couple questions that popped up in the chat.
Hey.
So the first one is, of these books, are there any that you would recommend for clients?
On this list, maybe not, but maybe the Saving Ourselves from Suicide book. But so many of these are directed at the clinician.
Our second question is, what do you do to decompress after a client does attempt or successfully commit suicide, or hospitalizing them? I find it really stressful and difficult, but like to learn from others.
Oh, and I would love to hear what others think if they would put it in the chat, but I have sort of my little self-care routine, and my number one self-care routine is when I really need to decompress. One, I go cry on Eric's shoulder, which is my new coworker here, and get it all out. And then I also will when I read books and stuff, when things are just too much, I absolutely refuse to read professional books for self-care. So I read things that are light and fun and fiction and could not possibly happen in real life to decompress. But I would love to hear what others say. I can, with the hand, basically one hand is just things that people can do. And I always tell them for a minimum of 5 minutes. So by the time you make it through that hand, it should be 25 minutes. And then on the other hand, the first 3 fingers are 3 people that they self-identify that they can call and talk to for 5 minutes and reach out to for support. The 4th finger on that hand is going over the things that they've learned in therapy. Are they doing all the things they've learned, all the coping tools? Are they taking their medication appropriately? And just reflecting on that. And then finally, the last one is calling a crisis line or whatever you've identified as the last possible step.
Another question in the chat is, sometimes it feels like the suicidal thoughts are so big and the risk so big that the person could just be in and out of the hospital, but other things could be better or safer long term. What are your thoughts about this?
Yeah, you're really talking, I think, Jessica, about those really chronically suicidal individuals is what I kind of get from that, which, I think that's where those DBT skills for us as clinicians can be so helpful, because I think we can offer our clients some tools to help them navigate that. And, I had a client who I worked with her for about 2 years, and it was this chronic in and out of the hospital situation. And ultimately, we just chipped away at things until we were able to get her in a space where she was doing much better. And we got some appropriate diagnoses, appropriate kind of interventions for that diagnosis, and she finally started doing better. And she has not been in the hospital since, and it's been about 10 years now. So there's hope. I guess that's my big message there. Oh, another question about teenagers. And I think we just feel that weight of responsibility with younger individuals more so maybe than, maybe it doesn't feel as heavy for us if it's an older person, but I think really that is really those self-care pieces. And, we've done everything that we possibly can do. And if we have, I think we have to recognize sometimes we still might not save a life. And it's hard to lose a client to suicide if you haven't already. It was tough as a professional, and you start to, at least I started to question everything about what I know, and if I had done enough, and if I, could have done more. And I spent a lot of time reflecting with people I care about and consulting, and really, really trying to get the benefit of many, many years of experience, not just mine. So, and lean on each other. Absolutely lean on each other.
All right, thank you, Jan. I don't see any other questions in the comments, and I do want to close out our event for today. But if you have further questions for Jan, you can email her or stay on for just a minute after my announcements and ask her questions.